The 5-year survival rate for pancreatic cancer is under 12%. Under 12. That number is not a typo. And the reason it is that low is not because the treatment is ineffective. It is because by the time most people over 60 feel that something is wrong, the window for meaningful intervention has already closed. Here is what makes this different from every other health warning you have ever heard. The pancreas does not hurt when it is being damaged. It does not swell visibly. It does not announce itself through pain you can track on a calendar. What it does instead is send signals. Quiet ones. 5 of them. Signals that most people over 60 explain away as stress, or aging, or something they ate, because no one has ever told them what those signals actually mean. In the next few minutes, I am going to show you exactly what those 5 signs are, where they come from inside the body, and what you need to do the moment you recognize any one of them. Because recognizing them early is not simply important. It is the difference between having options and no longer having any. I am Dr. Elizabeth Aliu, and this is the conversation your doctor should be having with you at every single visit. Before we get to the first sign, I need to explain something about the way this organ fails. Not the symptoms, the mechanism. Because once you understand how the pancreas breaks down after 60, the 5 signs I am about to show you will not feel like a list of warnings. They will feel like a clock you have been living next to without knowing it was running. Stay with me through the next 2 minutes. I promise you, what I am about to explain will change the way you listen to your own body. And if you are watching this because you already suspect something is wrong, with yourself or with someone you love, drop that in the comments right now. Tell me what you have noticed. I read every single one. You are not the only one watching tonight. Robert was 67 years old when he started losing weight. Not rapidly. Not in a way that alarmed anyone. Just quietly, over 5 months, about 14 pounds that none of his doctors could explain. He was eating normally. His appetite was reasonable. His energy was lower than usual. But everyone around him, including his physicians, attributed that to retirement. He was adjusting. That was the explanation that was accepted. And it was accepted for 8 months, until a scan done for an entirely different reason found a mass in the body of his pancreas. By then, the window for curative treatment had narrowed significantly. Robert's story is not rare. It is the typical trajectory, because the pancreas fails quietly, in a body part you cannot see, cannot palpate, and cannot monitor at home. And that invisibility is exactly what makes it dangerous. Here is what you need to understand about how this organ works, because it is the context that makes every sign that follows make sense. Your pancreas performs 2 jobs your body cannot survive without. The first is digestive. Every time you eat, it releases a precise enzyme cocktail into the small intestine. Lipase for fat, protease for protein, amylase for carbohydrates. Without those enzymes arriving in adequate amounts, your food passes through you largely undigested. Nutrients that should be fueling your brain, your muscles, and your immune system pass right through, unused. Now here is where it gets important. The second job is hormonal. Your pancreas produces insulin and glucagon, the 2 hormones that regulate your blood sugar every moment of every day. The insulin-producing cells, called beta cells, sit clustered inside the pancreatic tissue. When that tissue is damaged or chronically inflamed, the beta cells are damaged with it. And when beta cell function collapses, blood sugar becomes unstable in ways that are consistently misread as something else entirely. After 60, 2 specific biological shifts make this organ far more vulnerable than it was at 45. The first is accumulated chronic inflammation, silent, structureless, painless, driven by years of inflammatory dietary patterns, alcohol exposure, long-term medication use, and underlying metabolic conditions. No fever, no obvious signal. Just the architecture of the organ degrading over months and years until function begins to fall apart. The second is reduced regenerative capacity. After 60, the pancreas repairs its own tissue significantly more slowly than it did at 40. Damage accumulates faster than the body can address it, and that gap between damage and repair is the biological foundation for everything I am about to show you. Let us break this down, starting with the sign that shows up in the most unexpected place. Sign number 1, unexplained weight loss and oily, floating stools. Margaret was 63 when her daughter called me, concerned. Her mother had lost 11 pounds in 4 months without trying. Not from illness, not from stress, just a quiet, unexplained decline. She was eating her normal portions. Her energy was lower, but no one had flagged it as serious. And she had noticed something she was too embarrassed to discuss with anyone, including her doctor. Her stools had changed. Paler than before, oily looking, floating in a way they never had before. She assumed she needed to change her diet. She assumed it would pass. It did not pass. What Margaret was experiencing had a clinical name, steatorrhea. And steatorrhea is one of the earliest and most diagnostically significant signs of pancreatic enzyme insufficiency. Here is what was happening inside her body. When the pancreas begins to fail, one of the first enzyme populations to decline is lipase, responsible for breaking down dietary fat. When lipase production becomes insufficient, fat is not absorbed in the small intestine. It passes through the digestive system in its undigested state and exits in the stool. Pale, greasy, foul-smelling, floating. That is not a digestive quirk. That is visible evidence the pancreas is no longer keeping pace with demand. And the weight loss that accompanied it was not from lack of eating. It was from malabsorption. Every meal was being consumed, but a fraction of its nutritional value was reaching Margaret's bloodstream. The fat-soluble vitamins, A, D, E, and K, had stopped being absorbed. Her vitamin D had dropped, increasing fall risk and immune vulnerability. Her body had begun breaking down its own muscle for energy, and she had been explaining all of it as simply getting older. I want to ask you a direct question right now. Have you or someone you love noticed unexplained weight loss in the last 3 to 6 months, without any real change in diet or activity? Write the honest answer in the comments. I read every single one. What I want you to know is this. Unexplained weight loss alongside oily or floating stools in a person over 60 is not a coincidence. It is a pattern, and a pattern has a source. What to do? Ask your doctor specifically for a fecal elastase test. This is a stool test that measures pancreatic enzyme output directly. It is not included in a standard physical. You will need to ask for it by name. Ask for it. Today, if you can. Sign number 2, upper abdominal pain that radiates to the back. This is the sign most frequently dismissed, and the dismissal makes complete sense because the pain pattern is genuinely confusing, and it overlaps with conditions that are far more common in people over 60. Here is how it typically presents. There is a dull, persistent discomfort in the upper abdomen, often just below the left rib cage or across the center of the stomach. It tends to worsen after eating, particularly after fatty or heavy meals. It comes and goes across weeks or months. And then it does something that confuses almost everyone. It migrates into the back, not the lower back, the mid-back, between the shoulder blades or just below them, in a way that feels exactly like a muscle pull, or a mattress that has become too soft, or a pinched nerve in the spine. Most people over 60 who experience this combination manage the back with heat, rest, and over-the-counter medication. They never once connect it to the abdomen. Here is the anatomy that explains exactly what is happening. The pancreas sits immediately in front of the lumbar spine, against the posterior abdominal wall, directly overlying the network of nerves that run alongside the vertebrae. When inflammation begins inside the pancreas, from an obstruction, a developing cyst, or early cellular changes, the inflamed tissue presses against those posterior nerve fibers. Those nerves refer pain to the back. The back pain is completely real. The spine is simply not the source. 2 specific patterns are worth memorizing. First, pain that is noticeably relieved by leaning forward and worsened by lying flat on the back. This positional change directly reduces the mechanical pressure on inflamed pancreatic tissue. Second, pain that builds consistently after eating and eases during fasting. This is the digestive demand pattern. The pancreas is being asked to produce enzymes it can no longer generate without distress. Recurrent upper abdominal pain that radiates into the back and correlates with meals is not something to manage indefinitely with antacids and patience. Left unaddressed, sustained pancreatic inflammation does not stabilize on its own. It progresses. And in a body over 60, the distance between chronic inflammation and structural pathology is shorter than most people realize. This is not about fear. This is about having the information you need to make the right decisions. What to do? If you have experienced this pattern on more than 2 occasions, Ask your doctor specifically for an abdominal ultrasound and a CT scan of the pancreas. Request this by name. Do not wait for the pain to become severe. By the time it is severe, you have waited too long. Sign number 3. New diabetes or sudden loss of blood sugar control. I want you to think carefully about this one, because it is the sign most frequently misinterpreted, and misinterpreting it leads to years of treating the wrong problem entirely. Agnes was 71. She had managed her blood sugar reasonably well for 6 years. Metformin, twice daily, and it had been enough. Then, over roughly 4 months, her numbers began climbing without explanation. Nothing had changed in her diet. She had not become significantly less active. Her physician increased her medication dose and told her this was natural disease progression, the body's insulin resistance worsening over time. Agnes accepted that explanation. She had no reason not to. What no one investigated was why her body had suddenly changed the rules. The answer, as her imaging would reveal 18 months later, was that her pancreas had been compromised far earlier than anyone had thought to check. Here is what was happening inside her body. Your beta cells, the insulin-producing cells clustered inside the pancreatic tissue, sit embedded in the same organ that is under inflammatory attack. When the pancreas is damaged, the beta cells are damaged with it. Insulin production drops not because the cells have become resistant to signaling, it drops because the cells themselves are being progressively destroyed. Blood sugar rises as a direct consequence of organ failure, not insulin resistance. And that distinction changes everything about how the situation should be investigated. Researchers have a name for this: type 3C diabetes, also called pancreatogenic diabetes. Studies suggest it may account for as many as 1 in 10 new diabetes diagnoses in adults over 60. 1 in 10. Think about that for a moment. That number should stop you cold. Because here is why the distinction is so consequential. Type 2 diabetes is managed through medications that improve insulin sensitivity, medications designed for a pancreas that is still producing insulin but producing it inefficiently. In type 3C diabetes, the problem is not sensitivity. The factory itself is shutting down. Improving the delivery system when the source is failing does not resolve the problem. And more critically, it misses the window to investigate what is happening to the organ before the situation becomes irreversible. If you have received a new diabetes diagnosis in the last 12 months, or if blood sugar you once controlled has become suddenly unstable, ask your doctor one direct question. Has pancreatic pathology been ruled out? Ask specifically about a CA19-9 blood marker test. Ask about imaging of the pancreas. One question, 2 minutes to ask. And in the right situation, it changes everything. Sign number 4, yellowing of the skin or eyes. Here is the sign that carries the most urgency of everything I will say today. And it is the sign that people over 60 are most likely to watch, explain away, and wait on until the window has narrowed dramatically. It arrives gradually. The skin takes on a yellowish cast. The whites of the eyes follow. Urine turns the color of dark tea. Stools become pale and gray. This is jaundice. And in a person over 60, jaundice is a medical emergency until proven otherwise. Here is the anatomy that explains exactly why. The liver produces bile, a digestive fluid essential for breaking down dietary fat. Bile travels through the common bile duct into the small intestine. Here is the detail that changes everything. That duct passes directly through the head of the pancreas on its way to the intestine. When a mass develops in the head of the pancreas, whether a tumor, a significant cyst, or severe inflammatory swelling, it compresses that duct from the outside. Bile backs up inside the liver. Bilirubin spills into the bloodstream and deposits in the skin and the eyes. The urine turns dark. The stool turns pale. Everything visible in the body is telling the same story from the same source. What makes this sign uniquely dangerous in older adults is a single word: painless. In many early-stage cases, the jaundice appears gradually and without significant pain. No fever, no obvious crisis. Just a slow, progressive yellowing over several days. And the person experiencing it, and the people closest to them, attributes it to complexion, to lighting, to the natural changes of getting older. They wait, they watch, they assume it will pass. What to do? Go to your doctor or an emergency room immediately. Ask for liver function tests, serum bilirubin levels, and abdominal imaging. Ask for it by name. Do not leave without imaging. Because painless progressive jaundice in a person over 60 is one of the most diagnostically significant presentations in all of medicine. And I want you to carry this out of this section with absolute clarity. This is not optional. This is not a suggestion. If you or someone you love notices any yellowing of the skin or eyes, same day, not this week, not after the weekend, the same day. The people who caught this early all have one thing in common. They did not wait to be sure. Sign number 5, persistent fatigue and nausea. After eating, this is the sign that almost no one connects to the pancreas. It is the most common, it is the most persistently present, and it is the most dangerous to dismiss, precisely because its ordinariness makes it invisible. Someone you know has stopped enjoying food, not from appetite loss, not from nausea before eating, but because eating has become something that costs them. 30 to 60 minutes after a meal, a heaviness arrives. Not exactly pain, not exactly the fatigue of poor sleep. Something deeper, a systemic weight that settles in and does not lift until late in the evening. Low-grade nausea, persistent bloating that has become so unremarkable in the texture of daily life that they stopped mentioning it to anyone, including their doctor. They manage it with antacids, with smaller portions, with adjustments that help slightly but never fully resolve it. And they have filed it under sensitive stomach, or a digestive system that is simply showing its age. Let me tell you what is actually happening. When the pancreas can no longer produce adequate digestive enzymes, the digestive process becomes incomplete throughout the small intestine. Undigested food, particularly fat and complex protein, ferments in the gut. Bacterial balance shifts. The gut-brain axis, which connects the intestinal environment directly to the neurological sense of well-being, sends sustained distress signals upward. The result is a diffuse, persistent post-meal exhaustion and low-grade nausea that no antacid will touch. Because the problem is not excess acid. It is an absence of adequate enzyme activity several inches upstream. And no amount of dietary adjustment resolves a problem that originates in a failing organ. Now here's the piece I want you to carry out of this video above everything else. Every one of the 5 signs I have described today is a different voice coming from the same organ. Unexplained weight loss and oily stools, the digestive voice. Upper abdominal pain radiating to the back, the structural voice. Unstable or new onset blood sugar, the hormonal voice. Jaundice, the biliary obstruction voice. And persistent fatigue and nausea after eating, the enzymatic insufficiency voice. One sign alone may have an innocent explanation. 2 or more together in a person over 60 require investigation. Not reassurance. Investigation. Write in the comments right now. What have you actually been noticing in your body over the last 3 months? Be honest with yourself. Naming a symptom is the first step toward doing something about it. Action steps. Let me be very clear about what this means for you. These are not options to consider when convenient. These are actions, and the timing matters. First, if you are over 60 and you have never had a dedicated conversation with your doctor about your pancreatic function, not just blood sugar, not just digestion in general, but specifically your pancreatic health, that conversation needs to happen. Ask about a CA19-9 blood marker test. Ask about fecal elastase. If you have any established risk factors, a history of pancreatitis, heavy alcohol use, long-term diabetes, a smoking history, or a first-degree relative with pancreatic cancer, make explicitly clear that you want pancreatic health included in your routine evaluation. The barrier is not availability. The barrier is simply knowing to ask. Second, if you recognize 2 or more of today's signs in yourself or in someone you love, do not wait for your next scheduled physical. Call your doctor this week. Write down what you have noticed. Be specific about how long it has been happening and whether it correlates with eating. You are not being dramatic. You are doing exactly what every person who survived an early diagnosis did. They acted while the information was still incomplete. That is what early detection requires. It does not wait for certainty. It acts on patterns. Third, the dietary pattern most damaging to pancreatic health is not any single food. It is sustained inflammatory exposure. Reheated oils used in daily cooking, Diets consistently high in refined carbohydrates and chronic alcohol consumption at any level. Every meal either adds to the inflammatory burden on this organ or reduces it. That awareness alone is the beginning of protection. Fourth, send this to someone you love. It could change the conversation they have at their next doctor's visit. That is not a small thing. That is exactly what this channel is built to do. Disclaimer: your body is sending you signals. The question is, are you listening? If today's video gave you information you have been missing, subscribe to this channel. Every week I bring you evidence-based guidance on the health topics that matter most after 60, broken down clearly so it actually helps you act. And before you go, one important note. This video is for educational purposes only. It is not a substitute for personal medical advice. If you are experiencing any of the symptoms I described today, please consult your own physician. They know your history. They know your body. This channel exists to help you ask better questions at that conversation, not to replace it. Take care of your health. I will see you in the next one.